Level 1. The Claims Processor. Your screen loads at 7:58 de la mañana. By the time you log in, there are 19 items in your queue. By noon, you will have processed 68. The system times each one. You have learned to work inside the window. Your workstation is in a suburban office park in Arizona. 200 people do what you do, in rows of identical cubicles under identical lights. The building has no sign on the outside. There is no reason for one. The public does not come here. You earn $38,000 a year. Your own health insurance comes through your employer, the same company whose claims you process. Last spring, your son's occupational therapy was denied on the first submission. You knew exactly which code they used. You filed the appeal yourself. It took 11 minutes. It was approved on the second try. You did not tell your supervisor. The codes matter. Code 97, not medically necessary. Code 151, prior authorization required. Code 96, non-covered service. You move through them the way a mail sorter moves through envelopes, by shape, not content. What's inside is not your job. Your performance metric is called claims per hour. The target is 28. High performers hit 35. The top 10% receive a quarterly bonus of $450. You are at 27. Your supervisor noted this in your last check-in. Not as a threat, as a metric. The kind that follows you into the parking lot. You are not a doctor. You are not a nurse. You completed a 90-day certification covering HIPAA regulations, ICD-10 coding, and how to flag items for secondary review. You learned what medically necessary means in legal terms. You have never met a patient. When a claim fails the automated check, it enters your queue. You review the code against the coverage policy. You apply the rule. You move on. There is no field in the system for, "This seems wrong." There is a field for escalate, but escalations go to a team on a different floor. You have been here 4 years. You have never spoken to anyone on that floor. Your screen refreshes. A new item. Chemotherapy. Cycle 3. Supporting documentation attached. The patient's plan excludes the specific drug class. Code 97. Not medically necessary. You move to the next one. The form is in the queue. You processed it. That is all you know. That is all you are meant to know. Someone else will tell the patient. Level 2. The prior authorization specialist. Doctors call you. That is your job. You answer, review the requests, and determine whether the treatment being asked for meets the criteria in the coverage manual. You are not a doctor. That matters to the people calling. It does not change the outcome. You earn $46,000 a year. Your title is Authorization Review Coordinator. The word clinical appears in your division's name. This is not an error exactly. It is a framing. Your training lasted 6 months. You covered medical terminology, procedure codes, and how to navigate the prior authorization decision tree. The decision tree is a proprietary document. It contains clinical criteria developed by your company's medical policy team. You did not develop it. You apply it. A physician calls. She wants authorization for an emergery on a 52-year-old male with 3 months of lower back pain, unresponsive to physical therapy. She has documented the physical therapy. She has attached imaging reports. She is on hold for 16 minutes while you pull up the case. The criteria require 6 weeks of documented conservative treatment before imaging is approved. The patient has 12 weeks documented. You approve it. The next case is different. A 44-year-old with documented depression requesting a name-brand antidepressant after 2 generics failed. The plan requires a 3-step protocol. The patient has completed step 1. The criteria require completion of step 2 before authorization of step 3. You deny it and provide the appeals information. The doctor says, "This is the 3rd time I've called about this patient." You know the script. "I understand your concern. The criteria for this plan require..." The doctor hangs up. You have taken 47 calls today, 11 more before your shift ends. According to ProPublica, fewer than 0.2% of patients in ACA plans appealed their denied claims in 2021. You have never wondered why. You know why. You speak in a language that discourages further conversation. Precise, correct, impenetrable. The criteria have been applied. The answer has been issued. You move to the next call. Level 3. The case manager. You are a registered nurse. That matters to you. You went to school for 4 years. You passed boards. You worked in a hospital for 8 years before you moved to this role. You tell yourself you help more people here than you did in the ICU. Some days you believe it. Your job is to coordinate care for patients with complex or chronic conditions. The company calls them members. You call them patients, in your head, where no one can track it. You manage approximately 90 cases. You call them weekly, review their care plans, connect them with network providers. You earn $72,000 a year. The hours are better than bedside. You have not held anyone's hand while they died in 14 months. You are the only person with a clinical license who speaks directly to patients below the medical director level. That is not written anywhere. It is simply true. A member calls. She is 61 years old, manages type 2 diabetes, and her endocrinologist has recommended a continuous glucose monitor. Her current plan does not cover CGMs. The coverage decision is fixed. You cannot change it, but you can help her navigate the prior authorization process, document her history correctly, and file an appeal. The appeal will likely fail. You know this. Her plan has a specific exclusion, but you walk her through it anyway. You give her the member advocacy number. You note the call in her record. This is what care management means. Navigating the system on behalf of people who don't understand the system. Not changing the system. 2 years ago, your company implemented a new care pathway for complex cases. The pathway recommends routing members toward lower-cost treatment options before escalating to specialist referrals. You were told this was evidence-based. You were not given the evidence. You have watched members follow the pathway and come back 6 months later, sicker. You filed your concern through the internal feedback portal 3 times. You received a form response each time. Your license is real. Your training is real. Your care is real. And every day, you work inside a structure that values your credential as a buffer, as the human face on a system that would prefer not to have one, more than it values your judgment. The member is still on the phone. You tell her you will follow up Friday. You write that in the record. And then you move to the next case, because there are 89 others, and the week is not over yet. Level 4. The insurance sales agent. You do not think about claims. You do not think about authorizations. You think about the close. Your territory is the Southeast, Georgia, Alabama, Tennessee. You sell group health plans to mid-size employers, 50 to 500 lives. Base salary of $65,000. Commission structure that, in a good year, takes your total income to $130,000. Last year was a good year. Your clients are benefits managers at companies that make packaging materials, run logistics hubs, and operate regional restaurant chains. They have HR departments of 2 or 3 people. They're buying health insurance the way they buy paper towels, by price per unit, with some attention to brand. You show them the plan comparison sheet. 3 options: bronze, silver, gold. You walk them through the premiums, the deductibles, the out-of-pocket maximums. You do not walk them through the exclusions list. That is a 17-page document attached as an exhibit to the summary plan description. No one has ever asked for it. 80% of the groups you sell choose bronze, the lowest premium, the highest deductible. The premium shows up in the budget line. The deductible shows up in a worker's life when they get sick. You are not hiding this. You mention the deductible. You put it in the packet. But the packet gets signed, not read. The buyer needs a number for the CEFEO. You give them a number. You believe in what you sell. You have to. Your company's coverage is no worse than the alternatives. Most competitors offer identical plan structures with different logos. The industry is what it is. You did not build it. Your top client renewed last month, a distribution company with 220 employees. They switched from silver to bronze to reduce the employer premium contribution by $18,000 annually. You recommended the change. The renewal closed. You received your commission. In that distribution company's warehouse, the average worker earns $34,000 a year. Their new deductible is $4,500. You are flying to Nashville tomorrow. New prospect. 32 lives. Good shot. You close your laptop. The form hasn't been written yet. That happens after someone gets sick. Level 5. The medical director. You are a physician. This is important. The company employs you specifically because you are a physician. Your license is what makes the denial legal. You earn $425,000 a year. You have not seen a patient in 6 years. Your job is to review clinical denials and sign off on coverage decisions. In practice, this means you review decisions the prior authorization team has already made. You do not start from scratch. You confirm. In 2023, ProPublica revealed that Cigna's medical directors used a system called PXDX, Procedure to Diagnosis, to review and deny claims in batches. In 2 months, Cigna's doctors processed 300,000 claims at an average of 1.2 seconds each. One Cigna doctor described the process. We literally click and submit. It takes all of 10 seconds to do 50 at a time. Your company's system is called something different. You review a list of 140 cases each morning. The list has been pre-sorted by the clinical operations team. Green-flagged cases meet all criteria and are recommended for approval. You confirm. Red-flagged cases do not meet criteria and are recommended for denial. You confirm. Yellow-flagged cases require judgment. There are rarely yellow-flagged cases. On an average day, you spend 11 minutes on the green and red cases combined. You move through them the way a judge moves through routine motions. The outcome of each one has already been determined by the criteria document, a proprietary clinical policy your company developed, updated quarterly, not publicly available, not subject to external review. You did not write the criteria document. You were hired after it was written. At 4:15, you receive a peer-to-peer request. A cardiologist who wants to discuss a denial. According to industry data, peer-to-peer reviews overturn denials more than 50% of the time. You accept the call. The cardiologist explains. You listen. The criteria are clear. The denial stands. You write the note. You move to the next item. You have good hours. You have not missed a school play in 6 years. Your license is still valid. The form has been reviewed by a physician. That is what the law requires. Level 6. The Regional Vice President. You do not use the word denials. You use the phrase medical loss ratio. The medical loss ratio is the percentage of premium revenue paid out as medical claims. Under the Affordable Care Act, large group insurers are required to spend at least 85 cents of every premium dollar on actual care. Your job is to manage what happens to the other 15 cents, and to make sure the 85 cents stays as close to 85 as possible, without going over. Every dollar spent below 85% is margin. Your bonus is tied to margin. You manage a region of 1,4 members across 5 states, a staff of 300. You run quarterly business reviews with your actuarial team, your network contracting team, and your clinical operations team. In those meetings, the word patient rarely appears. The word member appears occasionally. The words that appear most often are trend, utilization, and unit cost. Trend is how fast medical costs are growing. Utilization is how often members use care. Unit cost is what providers charge per service. Your job is to compress all three. When your region's medical loss ratio rises above target, you convene a review. You ask which product lines are trending high. You ask which provider categories are over-indexing. You ask what interventions your utilization management team can implement. Interventions is the word, not restrictions. Not denials, interventions. You have a master's degree in health administration, 17 years in this industry. You have delivered 4 consecutive quarters of margin improvement in a region where your predecessor delivered 0. Your boss mentioned you for the national VP role at last quarter's leadership summit. You have not told your spouse. The form, the denial, the authorization, the appeal is a unit in a spreadsheet in a system you oversee. You do not read it. You read the number it produces. The number is trending in the right direction. Level 7. The Vice President of Government Affairs and Medical Policy. You write the rules. Not the laws, the clinical guidelines, the policies that determine what medically necessary means for 30 millones de people. Those are yours. Your team of 28 writes them, updates them quarterly, and defends them before regulators. You have a medical degree and a law degree. You earned the law degree part-time over 4 years while working. You have never had a private practice. You moved from medicine to policy before you had to treat anyone. You earn $520,000 a year, plus an equity package. Your work is invisible to patients. They never read the coverage determination guideline for musculoskeletal imaging, or the prior authorization protocol for specialty biologics, or the network adequacy policy for rural markets. But these documents govern whether their claims get approved. You write them with lawyers, actuaries, and medical consultants. You release them quarterly. You update them when regulatory pressure demands it. You spend 2 weeks each quarter in Washington. You meet with staff from CMS, from AHIP, the industry's lobbying body, which spent, according to Open Secrets, approximately $158 millones on federal lobbying in 2023, and from congressional committees. You explain your company's policies. You suggest language for future regulations. When Congress introduced a prior authorization transparency bill in 2022, your team submitted 47 pages of regulatory comments. The bill was delayed 18 months and substantially amended. You do not think of yourself as blocking care. You think of yourself as building a sustainable system. You have seen the actuarial models. Without utilization management, without the clinical criteria your team maintains, premiums would rise 20 a 30%. You believe this. There is a version of you that knows this framing is incomplete. You do not spend time with that version. The coverage guideline for GLP-1 medications, the new weight loss and diabetes drugs, is under revision. 17 stakeholder letters have been received. 2 congressional offices have called. You will issue the guideline in 6 weeks. It will determine whether 18 million members can access the drug. No one outside your office will know you wrote it. Level 8. The Chief Medical Officer. When the story runs, and the story always eventually runs, you are the one who answers. Your name appears on the press statement. Your face appears on the earnings call. You are the physician at the top of the clinical hierarchy, which means you are the human face of a system that has spent 20 years making its face invisible. You earn $4.2 millones a year. You finished a residency in internal medicine. You worked as a hospitalist for 4 years. Then you joined the company, first as a medical director, then as CMO of a regional division, then as CMO of the full enterprise. You still hold your license. You could, technically, prescribe medication. You have not done so in 11 years. Your job has 3 functions. First, you are the clinical voice in C-suite discussions. When the CEO asks whether a new coverage restriction is defensible, you give the answer. Second, you are the liaison with regulators, the FDA, CMS, state insurance commissioners, who want assurance that clinical decisions are made by clinicians. Third, you are the shield. The shield is not in the job description. When ProPublica publishes a story about automated denials, when a senator holds a hearing, when a patient's family needs a named executive to depose, you are the answer to the question, but is a doctor involved? You are involved. You reviewed the clinical policy framework. You signed off on the criteria document in a quarterly review meeting 18 months ago, in a slide deck with 47 other policy items. You have been deposed twice. Both cases settled. Both settlements included confidentiality agreements. The Coutret's earnings call is in 40 minutes. You will be introduced and will explain that all coverage decisions are made by or under the supervision of licensed physicians, that the company is committed to evidence-based care, and that the medical loss ratio reflects the company's ongoing investment in member health. You will say all of this with the steadiness of a person who has said it many times. The camera will be ready when you arrive. Level 9. The Division President. You run a 68 mil millones de dólares business. Not a division, a business. That is how you refer to it, and that is what it is. 11 million members, 4 product lines, 900 provider contracts, a workforce of 14 mil across 3 states. Approximately 4.3 billones de dólares in operating income per year. You are responsible for that number. You earn 7.8 millones de dólares a year. Corner office in a tower downtown. Driver on call. Private aviation for anything over 3 hours. You have an MBA from Wharton. 6 years in financial services before you joined this industry. You arrived because the margins interested you. They still do. Your quarterly business reviews cover EMI-LER trend, membership growth rate, net promoter score, and administrative expense ratio. You ask questions about outlier regions. You make decisions about pricing and resource allocation. You do not ask about specific cases. You do not know functionally what a prior authorization specialist does. You know that clinical operations is a cost center with a budget managed 3 levels below you. The word denial does not appear in your quarterly review materials. The phrase medical loss ratio appears 34 times. Your division is being considered for expansion into the Medicare Advantage market. This would add 2,1 millones de miembros y approximately 12,000 millones de dólares in revenue. The political groundwork is underway. Last month, a journalist called asking about a member in your division whose cancer treatment was denied 3 times before approval. Your communications team issued a statement. The statement said the company was committed to coverage decisions reflecting the best available evidence. It did not mention the member. You saw the statement after it was issued. You thought it was fine. Your briefing on the Medicare Advantage expansion is scheduled for 9 de la mañana. The car arrives at 8:30. The business is performing. The number is good. That is the form, you understand. Level 10, the Chief Executive Officer. You have 2 security guards now. You had 1 before December. You are responsible for the health coverage of 52 millones de people. You do not think of it this way. You think of it as a portfolio. 52 millones de covered lives. 370 mil millones de dólares in annual revenue. And a stock price that 200 mil institutional investors check every morning. In 2023, your total compensation was 10,2 millones de dólares, according to SECE filings. In early 2024, you exercised more than 20 millones de dólares in stock options. You have never written a coverage policy. You have never signed a denial. You have never spoken to a patient about their care. These things happen 5 levels below you, in systems you approved in aggregate, in strategies you endorsed as a category. You know the company believes in evidence-based medicine. You have said this to Congress. Twice. Once in 2022 and once in 2023, seated at a long table with your CMO and general counsel, under oath, in front of cameras. Your testimony was prepared over 6 weeks and reviewed by 11 lawyers. The question senators asked every time was some version of the same thing. How can a company report 22 mil millones de dólares in profit in a year when Americans are rationing insulin? You answered this question. You have a very good answer. It involves sustainability, risk pools, the relationship between premium levels and network costs. The answer is technically accurate. It does not answer the question. The question is about the space between a 52-year-old woman in Kansas who cannot afford her medication and a 10 millones de dólares compensation package. That space exists. The system was not built to close it. In December 2024, Brian Thompson, the CEO of your company's insurance division, reporting to you, was shot and killed outside a hotel in Manhattan. The gunman, according to court documents, targeted the institution. Not the man. The institution. You received this news at 6:42 de la mañana. By 7:15, you were on a call with your board. By 9:30, additional security had been arranged. By 1:00, trading in your company's stock had resumed, slightly down. By noon, it had recovered. The system did not pause. The system never pauses. The claims are still in the queue. The criteria document is still in effect. The form is still moving. Somewhere below you, in a cubicle with a flickering fluorescent light, someone is processing 68 items before lunch. You do not know their name. You have never needed to. At level 1, you process the form. You do not know what happens to it. At level 10, you signed the policy that created the form. You do not know what happens to it either. Between them, 9 layers of people who did not build this system, did not design its incentives, and cannot leave it. Because the salary is too high, or the job is too stable, or the next version of this system would look exactly the same. The form moves. The claim is processed. Somewhere, a decision is made by no one in particular. The cycle continues. There is a form. You have probably seen it, or the absence of it. A treatment request your doctor submitted. A claim you filed and forgot about. A denial letter that arrived 3 weeks later, written in language so careful it sounds almost kind. You have spent your whole life on one side of that form. This is what it looks like on the other side. At every level, from the fluorescent-lit cubicle where a claims processor moves through 68 items before lunch, to the corner office where a CEO with 2 security guards has never signed a single one. 10 levels, 1 system. Nobody in charge of